Hi, everybody. In this lecture, I'm going to add what you have already been learning about emerging diseases by talking a little bit more about the social context of epidemics. You've learned more about sort of the biological context. I want to sort of help you understand how these biological events also have very much a sort of sociocultural component that we want to also pay attention to. So that's what we'll be talking about in this lecture. So the most important point that I want you to take from the lecture is that epidemics are never just biological phenomena. That health and illness in general, and perhaps epidemics in an even greater sense, are social phenomena. And what that means is that there are both political and economic and sociocultural influences on our health. And particularly that influence when and how epidemics emerge and who is most affected by them. So if we want to analyze what's going on in terms of major health events, we need to think beyond the biological, beyond the strictly medical, and think about the social context. So that's really where I want to head with this particular lecture. As I mentioned in the introduction, we're going to talk about a couple of different epidemics. The first being Ebola, which is more geographically isolated, but still quite profound sort of health event. And then the second being COVID, which is obviously extremely widespread. It's a global pandemic. And I certainly wanted to talk about that because all of us have been living through that for the last few years. So let's talk a little bit about what you've been reading and watching for this unit and how it can hopefully help us understand more about the social context of epidemics. So the first thing that you read and then the first video after that are both centered on Paul Farmer, who, as I mentioned in the introduction, is a really important medical anthropologist. He is trained both, or was, again, as I mentioned in the intro, he sadly died earlier this year in 2022 at a fairly young age. So it's quite a loss for the profession and for all the people that he served. But Farmer was trained as both an MD and as a PhD in cultural anthropology. So he really brought together both that sort of biological or biomedical perspective and the cultural anthropology perspective. And he was particularly interested in the health concerns of people in the developing world and some of the poorest parts of the world, and really dedicated his life to understanding why and how it is that we have these tremendous sort of health inequities in the world, and how to try to address that with sort of channeling resources and addressing policies that will serve people who are, to this point, really underserved by global public health. So in the particular piece that you read by Farmer, he is speaking to you sort of from the being on the ground during the 2014 Ebola outbreak in West Africa. As part of his work as a sort of global public health advocate, he was there to sort of see what was going on and to try to assist in any way possible. So what you're learning about in that particular reading is, again, sort of the social context of the Ebola outbreak and the response to that Ebola outbreak. I think one of the most important things that he mentions in that article, and that he also reiterates in the interview that you watch after the article, is that Ebola itself is not to blame for the incredibly high death rate. The virus is, of course, a serious threat, but the bigger threat is the lack of what he terms as staff, stuff, space, and systems, right? So what he's basically saying is that weak health systems, particularly in the developing world, make it almost impossible for health professionals on the ground to do much in the face of a virus like that. So again, it's not the virus per se, in the sense that we have, as a sort of global human population, we have the technology to address that illness. Right? He even makes the claim that if the diagnosis and treatment available to people in the places of that outbreak were comparable to those in the US and Europe, that 90% of the folks infected with Ebola would survive, right? So the incredibly high death rate and the really sort of brutal circumstances of suffering from and dying from Ebola, he's saying, are not just about an especially virulent disease. That's a challenge, but the much bigger challenge is the fact that socioeconomic disparities in our world make it impossible for people in that space to actually address those diseases with the particular tools that we already have on hand, right? So as he says, quote, Ebola is more a symptom of a weak healthcare system than anything else. So the sort of narrative about Ebola, which was in the press and elsewhere, often about sort of what were deemed, problematic or exotic funerary practices, he suggests is not really what's going on there. That really a lack of global public health or equally robust global public health is the problem when it comes to outbreaks such as the Ebola outbreak in 2014, right? So what you have in these two Farmer pieces is, again, the reading by Farmer is sort of a dispatch from the field. So he's sort of reflecting on what he's experiencing in real time. The interview is some years later in 2020 when he has written a book about his experiences with that Ebola outbreak that he experienced, and also reflecting on how that connects to other sort of global health issues. So you're introduced both to Paul Farmer as, again, a really important medical anthropologist and the issues around global public health, particularly when we are confronted with emerging diseases or new, very acute public health issues. So the other thing that you read is the piece by Ali, and what Ali is writing about is another really important sort of component when we think about global health, and particularly about epidemics or major health events. And that is how people process those events and the sort of narratives and discourse that emerge around them. We've all just lived through several years of global pandemic, so I'm sure you're familiar with the sort of phenomenon of various stories emerging about COVID, where it came from, whether it was a natural event or something sort of engineered, the effects of the vaccine, whether what we're being told by public health officials is legitimate or not, right? And Ali is sort of taking that on, right? That issue of what are often called the conspiracy theories connected to COVID and other kinds of again, global health threats. And what Ali suggests is that although these conspiracy theories are often obviously very problematic from a public health perspective, right? That they get in the way of things like getting people vaccinated, right? We know that that's a phenomenon right here in the United States. That in fact, as researchers, as analysts, we should actually pay attention to what people are saying in those theories about health, about the experience of health, and particularly about epidemics, because they reveal something about the context in which people are experiencing that. And what they tend to reveal are geopolitical concerns, right? So those theories are not just about the disease itself, but about, for example, political relationships between nations, and whether people feel empowered or disempowered in the sort of current global political economy. Although certainly Ali suggests that it's an impediment to public health policy, she does suggest that we should sort of investigate what is being said in these conspiracy theories or these sort of ideas about the source and context of global disease, and take them seriously as reflections of people's both personal experiences and their ideas about what's going on in the world, right? So to sort of drill down into that, what Ali does in this article that you read is to look at 6 different narratives that she found in Pakistan, which is her primary research area as an anthropologist, to sort of see what the different kinds of ideas are that are bubbling up and what they reflect as far as how people are imagining their place in the world and the role of this particular, again, in this case, COVID, but any other sort of illness, as a manifestation of, again, international politics. She also notes that, when we think about conspiracy theories and public health, we need to think about, things like technology and how information spreads in the world. Certainly, this most recent epidemic or the pandemic of COVID, the spread of these ideas has been facilitated by the technology of the internet, which is a relatively recent phenomenon, right? So in that sense, this epidemic looks different than others in the past because the internet facilitates the creation and spread of various ideas about it, including ideas that compete with public health narratives or governmental edicts. And she makes the connection between that spread of what is sometimes misinformation or disinformation and the spread of the virus itself, right? So that we have sort of parallel propagating, right? So the virus is spreading from person to person, from community to community, and we have ideas about the virus and about treatment for the virus that are also sort of proliferating through those information channels that have been developed over time. So, sort of to wrap up some of these ideas, I wanted to think about those global health concerns and try to bring them back to patterns of health right here in Chicago. One of the things you're going to be looking at in this part of the unit is a film about how COVID sort of pans out in the Chicagoland area, and particularly the fact of the disparities around COVID that we can see in a quite inequitable and segregated city, right? So in other words, COVID does not affect everyone equally across the world or even across Chicago. So your sort of economic standing in the city and in the world will often inform the degree to which you'll be infected or affected by COVID and also infected by COVID, the degree to which you're exposed to the virus, and the your likelihood of getting timely diagnosis and treatment, right? So we see some real disparities in terms of who is really suffering the brunt of the pandemic. So to get to that, I wanted to sort of zoom out to thinking about global health, because one of the most important things that I think particularly medical anthropologists note is that the kinds of public health patterns that we see, we can look at them globally and we can find the same patterns sort of reinforced in local contexts. So in other words, if we look globally, the disparities between the sort of developed and developing world, or the richer and poorer parts of the world, are also reproduced in the richer and poorer parts of a city like Chicago, right? So in other words, we have sort of a macro version of those global health disparities and a micro version. And it's really important to see that connection, right, and that parallel between those two levels of analysis. So let's start with a sort of more of a global picture, and then we'll zoom into Chicago. So in terms of thinking about global health and how anthropologists, particularly medical anthropologists, think about this, we know that if we look across different parts of the world and both what people are sort of contracting in terms of disease and what people's sort of health profiles look at, how long people are living, what kinds of things people are dying from, etc., We know that there are obvious parallels between economic and political disparities and health disparities, right? So in other words, the disease profile in the richer parts of the world is quite different than the disease profile in the poorer parts of the world. All of these disparities speak to a history of inequity. So the legacies of colonialism, right, which we've talked about earlier in this course. So the inequitable distribution of economic and political power leads directly to what we see when we look at health. And indeed, the differences are quite stark. So, for example, I know earlier in the unit you learned about something called the epidemiological transition, which is the idea that sort of across human history, there have been several sort of moments where advances in knowledge and technology have led to better health outcomes in the face of the illnesses that exist, right? One caveat that we need to add if thinking about the epidemiological transition globally is that it hasn't happened in a sort of consistent way across the world. So in fact, the global south, in a lot of ways, has not experienced the epidemiological transition in the same way as the global north. If you compare global south and global north, you'll find that the global south suffers a much higher burden of disease, a much lower number of biomedically trained doctors per capita, right? Something that Paul Farmer mentions in what you read by him, right? In talking about Ebola in West Africa, he notes that part of the problem is the disease, but a big part of the problem is that even in places where there is a dedicated health staff, they don't have access to most of the stuff that they need, right? And there's too few of them to really address the needs of the entire population. So part of it is just a sort of issue of numbers, right? There aren't enough resources, enough trained personnel to serve the needs of the population. In the global south, we also find some sort of significant major markers of difference in terms of overall health, such as low life expectancy, high child mortality. So the life expectancy in the global south is considerably lower than in the global north, right? And that's both because people live shorter lives and because a considerably greater number of very young people, meaning infants and children, die, right, before they have the chance to live that sort of life expectancy. Another significant difference between the global north and global south is that the global south experiences, in terms of mortality or causes of death, the primary cause is infectious disease. So we have people dying of what in the global north are preventable or certainly treatable conditions, right? As opposed to degenerative diseases that tend to accompany old age. The other primary difference we see between the global north and the global south is that people are subject to political violence and other kinds of causes of illness and death, right, on a much wider scale. So if we really think then sort of worldwide about health and illness, we can see that there's really been a significant failure in terms of serving the people of the global south with the basic sort of technologies and medical advances that we've sort of accrued as a human population. Those advances have primarily served the people of the global north, not of the global south. So just to sort of illustrate what I've just been talking about, and I think often looking at a map is helpful because it helps you visualize those stark differences. So if we look at something like healthy life expectancy at birth, right, which is sort of how long you're expected reasonably to live given the statistics for the sort of duration of your life. If you look at this world map, you can see that those life expectancies correspond to a certain extent to political economic power, right, in the world. So most notable here is the fact that the sub-Saharan Africa has a significantly lower healthy life expectancy at birth than the rest of the world, and certainly than somewhere like North America, right? So in the 40 to 50 year range, as opposed to somewhere like Canada, which is in the 70 to 80 year range. Likewise, here's a map showing under 5 mortality. I mentioned that high child mortality, that is infants and children dying, is a sort of key indicator of sort of the relative health of a population. I'm giving you a comparison between 2000 and 2015 here to demonstrate that, in fact, we are making progress as a global population as regards health. But it still is obviously tremendously inequitable. Even in the 2015 chart here or map here, you see that we have much higher under 5 mortality in South America and in Africa than we have in the US and Europe. Likewise, if we think about causes of some of those health inequities, things like access to clean drinking water is a key one. Diarrheal diseases are one of the major killers in the world. So if you look again here at the percentage of the population who has access to clean drinking water, you see those same inequities. Again, on the left is 2000, on the right is 2015. Progress, yes, and yet ongoing disparities. And then a final sort of marker, and this one about a more commonly understood as a degenerative disease, which is cancer. If we look at a disease like cervical cancer, something quite specific, and the probability of a woman dying of cervical cancer. If we look globally, we can see tremendous disparities, again, between the developing world and the US, Canada, Europe. Cervical cancer is, in fact, one of the most preventable and curable forms of cancer, right? So if there is early detection, it is quite treatable, right? So it is not a death sentence. This is not a question of the virulence of cervical cancer. What we do know, though, is that in different parts of the world, women are more or less likely to get that screening that allows for early detection and to get that early treatment. And that's really the primary difference we see when we look at this map and the probability of death for women across the world. It's not that cervical cancer is somehow stronger or more of a death threat for women in South America or on the African continent. It's that those women are not getting access to the health resources that they need, right? So this is a human problem. This is not a problem of the biological or the medical phenomenon of cancer. This is a human, a social problem. And that is the reason that people are dying at significantly different rates from this particular disease. Now, as I mentioned earlier, I really want to make the connection between those sort of global health disparities and what's going on locally, right? You are going to be watching a film about COVID disparities along the lines of race in Chicago. So I was just talking about those sort of global disparities around cervical cancer. So that's the sort of that's the macro lens on that particular disease. Well, let's look at it now in a micro way. So if we look at cervical cancer deaths in Chicago, what we can see is that the disparities that I showed you on the previous map, those global disparities, are mirrored in local disparities across the city. So, for example, women living on the south side of Chicago are much more likely to die of cervical cancer than women on the north side. that's not because the disease is a different disease between the north and south sides of Chicago. It's because people in different parts of the city have very different access to appropriate screening, diagnosis, and treatment for the disease. And that is a socioeconomic disparity. So again, when we think about disease, right, any kind of disease, including epidemic disease, there's a social context, and that social context has a lot to do with how well people fare when faced with these health threats. Likewise, I mentioned that COVID affects people differently. Likewise, people have different access to the treatments for various kinds of health concerns. So in terms of the COVID pandemic, which differently affected people across the world, the other thing that we find with COVID is that people had different amounts of access to the vaccine, right? And indeed, the co-chair of the African Union's COVID-19 Vaccine Delivery Alliance pointed this out. In a quote, she says, "We advocated, begged, pleaded that high-income countries share doses and support TRIPS, which was this program to get doses of vaccine to the developing world, and local production of vaccines on the continent. They largely refused. This was inevitable, but completely avoidable. Travel bans are not the answer. Urgently vaccinating the world is." So again, we see both at the sort of source of health problems and in things like screening, diagnosis, and treatment, a lot of inequity the world over. So this is why epidemics take the form that they do, right? It's not about some kind of biological component. It's really about a social and, by extension, an economic and political context to these diseases. So as I said, I want you to end by watching The Great Divide. This is a really interesting film, and I think it will really sum up that sort of global local connection that I've been referring to by really showing how this global pandemic has manifested in Chicago, and how it has followed the lines of existing disparities. So this film is really about how COVID has played out in terms of affecting different populations within the city and along the lines of race and ethnicity, and how people, again, depending on their sort of socioeconomic position in the city, have very different experiences with the disease, including things like access to vaccination and treatment. So I hope that you'll enjoy the film and that it'll sort of wrap up some of the things we're talking about here. This is a really important issue. It's very close to my heart as a medical anthropologist, and I think it's something that affects all of us. It's certainly been top of mind for the last several years as we've all been living through it. So I'll close there, and we'll talk again soon. Bye-bye.